So I want to start first with talking about medical management. It's something that's so important. We oftentimes jump the gun and start saying, let's go ahead and operate on someone. But we forget a fundamental element, which is the fact that hair loss is progressive in nature and that medical management can be a very, very important tool. Sean, can you roll the 10-minute time on this? So here's the key. There's two FDA-cleared medicines, finasteride, also known as Propecia, and minoxidil, which is Rogaine. The non-FDA-cleared one specifically for alopecia is dutasteride, which is for benign prostatic hypertrophy. We're going to talk a little bit about that in case your patients ask or you want to incorporate that. We're also going to investigate in the female patient the idea it's not just giving them Rogaine, but also understanding there's other components that contribute to female hair loss, and it's very important that as a hair transplant surgeon you understand those elements. We'll talk about that in a moment. The real key with this is that hair loss is progressive, and so even if you transplant the patient, they're going to continue to lose hair. And not everyone's a candidate for hair restoration. You have someone at 20 years of age starting to lose hair, rapidly progressing. You're going to have a situation where you can have an unnatural result appear over time, and they're actually a very good candidate for medical management. So remember one thing is that if the patient is losing hair, don't just think about putting hair back in, but consider slowing down that speeding train of hair loss, even if you're going to do a hair transplant. Because if you do a great hair transplant, I like the saying of Vidal Sassoon, if you're old enough, is that if you don't look good, we don't look good. And the concept behind that is that whatever we give you in transplant, if the other medical management is slowing down the loss, increasing some of the thickness, your result actually looks better. And that's really, really important to combine it even with surgical transplant. Let's first talk about finasteride. This is the workhorse here. And finasteride at the 5 milligram dose is known as Proscar, and at the 1 milligram dose for hair loss is known as Propecia. It is a 5-alpha reductase inhibitor type 2. It blocks the conversion of testosterone to DHT. And the idea here is that DHT is what creates problems with male hair loss. And let's take a step back and understand this, because it's not like one day you have hair, then you don't have hair. Male pattern baldness is about a transition from full, thick terminal hairs to baby, wispy, vellus hairs to zero hairs. And the real key with finasteride and Rogaine is taking, Danny, I'm going to start and then I'll let you do the next one. You're going to take those baby vellus hairs and move them back into full head of hair, or to the fuller, thicker hairs. But once those hairs are just gone, the finasteride is doing very little to work on that. And just to make that clarification, finasteride is an oral pill once a day at 1 milligram versus Rogaine, which is a topical application, which we'll talk about further. Let's compare the 5 milligram Proscar dose versus the 1 milligram Propecia dose or finasteride dose for hair loss. They actually both reduce DHT pretty similarly, and there's been studies that show that. The PSA is actually halved, and so especially in someone older, you make sure that the doctor knows that they need to double the PSA score so that they get a good, accurate understanding of what their PSA situation is. Prostate volume actually is very similarly reduced, but the voiding symptoms are significantly improved with the 5 milligram dose. Hence, that is why the 5 milligram dose is indicated for the gentleman with prostate issues, and the 1 milligram dose is sufficient for hair loss. The side effects we will talk about further in a moment are very similar in profile between the 5 and 1 milligram dosing. The finasteride, as I said, works on miniaturized hairs, those baby vellus hairs, and getting them to thick terminal hairs once again. It does not work on slick baldness. When someone comes in with a Norwood 6-7 and they've got nothing on top, it may slow down the further progression of existing hairs, but you're not going to really thicken any hairs that don't exist. So that's something very, very important. So it slows down that speeding train. Really, really, if you're going to consider hair restoration, you must understand how to use these medications for your patients. The other thing that's a big misunderstanding is some of the early FDA trials showed the benefits of finasteride and Rogaine in the crown, but it works globally, and that's something that patients will be confused about. Some of the outdated package inserts talk more about the crown, but it really works in a global fashion across all areas of the head. And finasteride takes about 6 to 12 months to work. The other thing that I think is really important, if you're going to consider a hair transplant and you look in there and you see, let's say 70% miniaturized or these vellus hairs all over over the place. If you go in there and you start transplanting into that, that thing is going to shed all over the place, and you can have a semi-bald patient for about 4 to 6 months, and they're not going to be very pleased with you. So if you see a lot of these baby hairs or vellus hairs, truly consider perioperatively, maybe a few months before, to stabilize those hairs. And what that means is that it may not grow completely back into a terminal situation, but there's a less chance of shedding in that sensitive 3 to 4 month window following a hair transplant. The other concept behind this is it doesn't just work in that first year. They've shown studies out to 5 years that if you look at the bottom chart, if you look at the bottom line here, this is just natural progressive hair loss without intervention, and this is ongoing stability of finasteride over many, many years, so something to consider. But the other thing we're going to talk about is if you do stop it, you actually lose everything you gained over the period of time you're on it, which is discouraging. But it's something that's important. You describe that to your patients. The side effects. There's erectile dysfunction, loss of libido, we heard about this, breast tenderness, and 58% of these resolve with ongoing therapy. And if you look at it's about 3.8% versus 2.1% placebo. The side effects usually should stop when you stop it. There are some rare case studies of persistence of side effects, and something that I think is important to know, but it's pretty unlikely that that should be the case. Finasteride and the prostate. I just want to walk you through the last few years of understanding how we've come to think about finasteride and the relationship to the prostate, because you're taking a medication that is systemic in nature. And the idea, besides just having the PSA value, it also is important to understand that some of the early studies, 2005 or so, 2006, were looking at the fact that there's possibly a higher chance of prostate cancer with taking finasteride, and then they found that to be truly a pathologic artifact, that there was a shrinking of the prostate, and that they found these higher grade tumors only because of the artifact of biopsying a higher likelihood of finding the cancer. If anything, they've actually shown in the 2008 studies there's been about a 25 or 30% reduction in long-term prostate cancer risk with ongoing finasteride at the 5 milligram dose. So I hope that wasn't too confusing. But the concept behind this is that we don't know what it really does at a 1 milligram dose, but at a 5 milligram dose, there can be possibly long-term protective value against prostate cancer at a rate of about 25 to 30% reduction. The other just an important idea is that finasteride can also be something that could be, you shouldn't give it to professional athletes, or at least counsel them that this could be something that's banned. It's important. For finasteride in women, it's very unclear exactly if it's beneficial. Obviously, in the premenopausal setting, you're very worried about a teratogenic effect on the male fetus. But in postmenopausal women, some of the early studies with Price and Whiting showed that there was no benefit in a controlled setting. Iarezzo in 2006 showed that there was possibly a benefit. It was a very uncontrolled setting. But there is some consensus that in postmenopausal women that are experiencing hyperandrogenism, a unique subset could actually benefit from finasteride. How do I use it? Generally speaking, I don't use it in postmenopausal women, but I have, in an anecdotal fashion, done it in select patients and shown that there's been, again, uncontrolled improvement, always combined with Rogaine or minoxidil. Cost is about $60 to $80. Just stay on time. I'm going to move forward with this. And the patent continues to 2013. Minoxidil. Minoxidil was first approved for blood pressure orally. It's now topical for hair loss and is applied to the scalp, not to the hair. Very important. It is recommended to be applied twice daily. There's some thoughts that in the skin it can actually have about a 20-hour half-life versus just a 4-hour serum half-life. So I tell my patients that even if you're going to do it once a day, it's a heck of a lot better than doing it 0. So just something to think about. It comes in 2 and 5% doses, with the 5% being for men. And there's not really a clear idea of how it works, but if you can remember, one thing is that it potentially can prolong your anagen phase. And that's something that we'll talk about in just a minute, what the importance of that is. It is over the counter. The major side effect in the non-branded version is scalp dermatitis or irritation in an order of maybe about 25%. The branded version, they came out with a foam that only comes in the 5% at this time, where they remove propylene glycol. So patients that have had sensitivity to the non-branded version, you may want to suggest for them to get the branded version that's foam. It's also a little bit easier to style. The other thing that's important is in your first 6 weeks, because you're actually moving hairs into an anagen phase, you can have a little bit of shedding shedding of the hairs, and that's actually a good sign. So you need to tell your patients that so they don't panic when they see that. I do use the 5% in women as well, but there is a higher risk of hypertrichosis with that, and that's just something a patient should know about. The reason I do it is if I really want to more rapidly stabilize them over that first few months to a year, I like to use the 5% in select women. And the idea is that there's been some studies after about a year that the 2 and 5% have very similar clinical efficacy for women after that point. I'm going to skip over that last point. And there is an effect that occurs a little bit earlier, about 3 months out, you start to see it earlier than finasteride, and as the studies show that there's ongoing improvement over the long run. And just like finasteride, if you stop using it, you lose everything you gain. This is just talking about, we already covered that. Just for the sake of time, I'm going to move forward with this. And I also use it to stabilize telogen. Really, really important. In other words, if a patient has a high risk of shedding after surgery, it's a great idea to start a few weeks to a few months before with minoxidil. Patients that have a lot of sun-damaged scalp, that their vascularity looks bad, the minoxidil could help improve that area a little bit before in a perioperative setting. You do want to stop it a couple days before, just because increased vascularity could lead to a little bit more intraoperative bleeding, and restart it about 7 days post so there's no irritation with the grafts in the early setting. So the idea between finasteride and minoxidil, Amina likes to describe, Amina is working with me as a transplant coordinator, likes to talk about like a piano. If you're playing with one hand or playing with the other hand, it's like playing with both together. And in other words, they work really synergistically together. Dutasteride, I'm not going to spend too much time on. Dutasteride it's a type 1 and a type 2 5-alpha reductase inhibitor. Market is Avodart for BPH. I really rarely use this on patients, but it's something that they've shown that it can actually, because it's a both type 1 and type 2 inhibitor, that there can be an increased efficacy with this medicine. And the half-life is much, much longer. The cost is, I think, similar. It's about $2 a pill for this medication. Just got back from Amsterdam and heard some phase 3 clinical trials that showed good clinical efficacy with this and a very similar side effect profile to finasteride. Hormonal therapy, I just want this slide up here because it's so important. If you're going to do hair restoration in women, you really, really need to remember taking care of, I think Danny's going to talk a little bit about this, is just really understand you got to do some investigative work and not just treat them and not just start transplanting them. And low ferritin levels, dihydroepiandrosterone sulfate, which is the most predominant male hormone in a woman, needs to be checked along with the full range of hormones. Low thyroid levels, any kind of risk of a autoimmune disease, and obviously just a basic chemistry profile. Obviously, there's a lot of stuff patients going to ask about on the internet, and I always want to be careful when I give a talk, not to say it's good or bad, but just to focus on what's FDA cleared. And so some conclusions here is that just remember a few things. Finasteride and minoxidil really are synergistic, and they slow down the speeding train of hair loss, whether you're going to do a hair restoration or not. It's really better for the early patient that still has those baby hairs, or not completely into slick baldness. And think about it in tandem with your hair transplant. If you're having someone with a lot of baby hairs or vellus hairs that could be shocked post-operatively, you really want to stabilize those hairs to the best of your ability in the perioperative setting. Maybe a few months on these medicines will help a lot. And the other thing is, the sad thing is, if you stop using them, you lose everything you gain. And just remember, in women, we'll hear probably from Dr. Russo a little bit more, but just the idea is just remember, don't just transplant them, really investigate that. So, course that we're doing in St. Louis, I'm really proud of. Talk about that further. And Danny, do you want to come up and do yours? Sure.